All right. Thanks very much for joining me today. It's very exciting to be here. Very excited to give this talk. This is a talk that I actually had prepared for EMU 2020. So I'm excited that I finally get to give it. Um, Two of the topics that I most like talking about and teaching about are airway management and crisis resource management. And this talk is going to talk a little bit about both of those things kind of mashed together. So if either one of those appeal to you, hopefully this talk has some teaching points for you. So my name is Jesse Guscott. I'm a rural generalist. I work in Collingwood, Ontario. My practice includes anesthesia and hospitalist. I did emergency medicine for a long time as well. I also teach a bunch of courses. I do some simulation work, a course called SCORE. I teach the AIM course and a course called HIC as well. I don't have any disclosures. I don't have any financial conflicts, but I will use a couple of slides that are watermarked from some of those courses, and I do get teaching stipends when I teach those courses. So objectives for today, I want to identify some ways in which physician stress responses can impact us in our decision making, particularly in airway crises. I want to talk a little bit about some strategies and how we might mitigate that, and we'll incorporate some technical considerations as well in thinking about how we might manage a can't intubate, can't oxygenate scenario. So my story starts on a Friday afternoon. It's a sunny Friday in the summer, and I'm not on call and I don't have any shifts. And so I'm starting to daydream about what my weekend's going to look like. And just as I'm walking in the lounge to go get changed to call it a weekend, I hear code blue in operating room number one. Pretty uncommon thing in my venue. We don't do a lot of super high risk surgeries, and we certainly don't have a lot of codes in our operating room. So I take off down the hall, run into operating room number one, and when I get there, initially my eyes are drawn to the monitor. And I see something that looks like this. So normal sinus rhythm, patient's got a pulse and a heart rate, oxygen saturations are pretty reasonable, patient has a blood pressure. My colleague's at the head of the bed, and she looks at me and she says, I've been in the airway a couple of times and I have no idea what I'm looking at. I can't get a tube in and I'm having trouble ventilating this patient with a bag mask. So, at that point in time, I'm feeling pretty clear-headed. This is a scenario that I'm pretty familiar with. I've practiced lots of times. I've studied lots of times, certainly simulated a lot of times. So at this point, anyways, I feel like I can manage the situation, and I declare what I hear, which is this sounds like a can't intubate, can't oxygenate scenario. Thankfully, everywhere that I manage airways, I've stashed a little can't intubate, can't oxygenate kit. So there are scalpels and bougies and endotracheal tubes pretty much everywhere that I manage airways, including taped to the side of our anesthetic machine in the operating room. So at that point, I don't think my brain's actually thinking we're going to need this, but I do take out the scalpel, the bougie, the endotracheal tube, and I lay it on the patient's chest when I announce that this sounds like a can't intubate, can't oxygenate scenario. I talk about the next steps in the algorithm. So my colleague is just starting to put a supraglottic airway in to try to ventilate through that. And I organize the team and say, if this doesn't work, we're going to try one more attempt at bag mask ventilation with two-handed technique. And if that doesn't work, we're going to access the airway through the front of the neck. A general surgeon's run into the room with me. It's actually an elective general surgery case that's on the table. So the general surgeon was waiting in the lounge, for the patient to be asleep and intubated. So he's now come into the room. So I've advised him to start thinking about prepping the neck. At that point, my heart rate's starting to go up. So while initially it did feel, kind of like a fire drill, and I felt pretty relaxed and knew my algorithm, when that supraglottic airway failed, things started to get a little bit more heated. I remember starting to lose my peripheral vision, as things got more stressful. So I stopped sort of seeing and hearing things that were on the periphery, and all I could focus on was this head that was in front of me that was getting bluer and bluer every second. So when we realized that the supraglottic airway was failing, we went to two-handed bag mask ventilation. I put an oral airway in. I gripped that face as hard as I could, big jaw thrust. I had an RT squeezing the bag, and no air was moving in or out of that glottis. Um, this is a picture of what the glottis looked like. Obviously, we didn't stop and take pictures in the moment, but after we finished managing the airway, this is what my colleague had seen from above. and there's no doubting that that's why the air wasn't going in and out. The glottis is actually swollen shut. So at that point, we realized that this isn't working. The bag mask ventilation isn't working, and this is where my mind started to play tricks on me. There was a fleeting moment where my brain said, "Mm, this can't be a can't intubate, can't oxygenate scenario. You just need one more attempt at intubation." And I had thought about this scenario a lot of times, and thankfully I was able to kind of manage that fleeting thought and push it aside, and progress down the algorithm. But I won't ever forget that moment where my brain did try to trick me. I declared the algorithm again and advised the surgeon it was time to go ahead and access through the front of the neck. I would put the time that I was in the room till the time we put knife to skin on the neck at about 90 seconds. So it was about 30 seconds with that first attempt at the supraglottic airway, a bit of a transition time, and then some time with our attempt at bag mask ventilation. And in that time, the oxygen saturations had dropped from the 93 when I walked in the room to about 8 was the lowest that people saw. So single digits. I never saw those numbers, but that's what people told me after the fact. So I looked at the surgeon and said, we need to access through the front of the neck, and the surgeon made a cut. We had his bougie and the scalpel, and we were able to proceed with that pretty quickly. He put the bougie down, and I railroaded the tube over the bougie. We were able to access the airway through the front of the neck. Patient reoxygenated very, very quickly. I would say in a couple of breaths was already starting to reoxygenate. Within a minute was back up into the 80s and then into the 90s a couple of minutes after that. The patient survived and was completely neurologically intact. They went on to a larger center, a referral center for a formal tracheostomy. And in the referral center, a parade of ENTs and intensivists did try to intubate from above using all kinds of tools. They weren't even able to drive a bronch through that glottis as it was swollen closed. We think the diagnosis was angioedema secondary to an allergic reaction from one of the induction agents or the antibiotics, though testing did not identify what the culprit may have been, but certainly, as you saw, there was a ton of edema in there. So, lessons learned. First of all, your brain will shrink in crisis. The second is we need some strategies to try to manage that, to try to prepare for that. And airway management should be, like every other crisis, a team sport. An approach to managing the airway algorithm is to plan, to communicate, and to execute. I'll just go through those three with you here. The first is your brain will shrink. So in the moment, again, when we first came into the room, when things were sort of calm, cool, and collected, heart rate is at a reasonable level, I was able to evoke the airway algorithm to a pretty good degree. But as we started to get further and further down, it became harder and harder to do that. So when we think about stress responses to fear, you may have seen this graph before, and where we want to be is in this combat ready zone, somewhere in the 115 to 140 heart rate, where our brain preferentially uses its energy on things like complex motor skills, visual reaction, cognitive reaction time. So this is our, primed for combat, primed for running away from lions, type mode, and that's where you want to be. Interestingly, here's a printout from my my Apple Watch. This was a day that I got called to the emergency room stat to intubate a 20-year-old who had popped a clot off of her tonsillectomy. So it was about a week post tonsillectomy. I ran into the room, and the patient had about 2 liters of blood in K basins and was actively vomiting, and it was my challenge to intubate her. So you can see my heart rate responded appropriately there, and I'm in that combat ready zone. That's kind of where you want to be. Unfortunately, in this can't intubate, can't oxygenate scenario, I got way up higher into this zone where I actually did lose my peripheral vision, which was quite an experience. Because we know we're going to have these types of stress responses, we're going to have these types of physiologic responses, we're going to need some ways to manage them. Now, in a lot of scenarios, we're going to be able to improve our stress responses by practicing, by doing simulations, by stress inoculation, but there's still going to be these experiences that overwhelm our preparation. So one of the ways we can get around that is to make our crisis responses a team effort. So this story really is not a story of me coming in and saving the day. Quite the contrary, actually. I think this is a story of my colleague saving a life by calling for help. If you'll recall, when I came into the room, the patient had a normal heart rate, pretty normal oxygen saturations, 93%, had a blood pressure. Yet my colleague had called a code blue in that situation. And I really think that that was the defining moment of this resuscitation. I think that's the thing that saved this patient's life. I think it takes a lot of courage. I think it takes a lot of humility to take a scenario like that, and have a disruptive code called in an operating room. And again, that's a thing that does not happen in my institution very often. So I do think that that was the thing that changed things for the better. And that she called when she did was the only thing that saved this patient's life. Even with calling so early, with normal oxygen saturations, with normal vital signs, by the time we went through the last remaining maneuvers in the difficult airway algorithm, that patient had desaturated into single digits. And I don't think that patient would have survived if had she waited another 2 or 3 minutes before calling for help. Her challenge was she was at that point trying to play all of these roles at the same time. She was trying to be the decision maker, she was trying to be the proceduralist, and she was trying to navigate the technical and logistic challenges of this airway management. And when she called for help and other people came into the room, we were able to divide those tasks. So I was able to move into the role where I was the decision maker, I was driving the algorithm, and that was a pretty comfortable role for me, again, because I wasn't emotionally invested with this patient, didn't feel fundamental responsibility for this patient. I think I had a little bit more objectivity and was able to play that role okay. The general surgeon who came into the room was able to play the role of proceduralist. They're primarily a technician, and when we're talking about it afterwards, that dynamic of separating out the proceduralist from the decision maker, I think also gave us a little bit more of an expedient approach to the airway. So I think if when I was there, with two hands on the face, trying to oxygenate and making the decision to go forward and access through the front of the neck, I think if I had to be the one who was going to cut, it probably would have taken me another 10 or 20 or maybe even 30 seconds to actually get my head around that movement. When we talked about it, the surgeon said the same thing, which is that if he had to make the decision on when we needed to cut, he might have delayed another 10 or 20 or 30 seconds. But the fact that that decision was being made by a different person from the person who was actually going to execute, I think was one of the things that allowed us to proceed. I made the call, said we should cut. He felt like he was in a position, to do the technical task and not question that, and we were able to proceed very quickly. My colleague, who was initially the team lead, moved into a logistics and a support role where they were able to get the next equipment, get the bag ready, get the oral airway ready, queue us up for our next steps. That division of responsibility, I think, was really useful in this situation. So another way that I think that we can approach, the inevitable shrinking of the brain and cognitive limitations in crisis is to make a lot of our decisions before we get into that situation, before our brains start to shrink. So before we end up, committed in an airway, we need to plan, we need to communicate our plan, and then we need to execute our plan. So it's clear to me that in crisis, this difficult airway algorithm that's published by the American Anesthesia Society is not a useful document. This was not an algorithm that I could evoke in my head. There's too many arrows, too many branch points, too many decision points. So I've redrawn that algorithm, and I think it needs to be a straight line. So until we have gas exchange, I think we need to just proceed down the algorithm until the end. And when we're committing to an airway, we're committing to gas exchange by whatever means necessary. Now, once you have oxygen exchange, whether that's in the first step or the third step, you're off this algorithm. You can make decisions about what you want to do, whether you want to try another attempt at intubation or whatever. But until we have gas exchange, we need to progress in a linear fashion. So for most of us, when we're managing emergency airways in the emergency department, our first attempt is going to be laryngoscopy, often video laryngoscopy, and whatever is your first approach at getting a tube in. We have our primary means of intubation. If that's unsuccessful, we want to try to reoxygenate the patient with bag mask ventilation. And if that's unsuccessful, we're going to move to a rescue device, which is usually going to be a supraglottic airway. You'll pick the supraglottic airway that you're most comfortable with. For me, it's an LMA, but for you, it may be a iGel or a King LT or whatever happens to be your device of choice. That rescue device is our last opportunity before we access the front of the neck. And I think anytime you're putting someone to sleep, you're paralyzing someone, you're trying to do an awake intubation, you're committing that that patient's not going to die for lack of oxygen in their lungs. You're committing to getting oxygen in the lungs by whatever means necessary. Once you've drawn up your plan, and in some scenarios, these might be in a different sequence. A supraglottic airway might actually be your first option in some of these scenarios. They can be juggled around, but once you have your plan, you need to communicate your plan to your team. When I'm in difficult airway situations, or really any emergency airway situation, I really make a point of doing this every time. I communicate my plans to my team. I make sure that that equipment is at the very least in the room. I don't necessarily get the scalpel out every single time and make sure that it's visible, but I do make sure that it's in the room, and I verbalize that. I verbalize this plan from start to finish, and then I turn to my team and I empower them and I say, listen, now you all know the plan. These are the steps we're going to take. If you see me getting stuck, if you see me failing to progress down the algorithm, it's your responsibility to nudge me. I think if we create team dynamics where people feel empowered to help you, to push you, to nudge you, they will do that. But if we create this dynamic where the physician is the king, is the ruler, is the leader, not to be questioned and not to be distracted when they're in the middle of airway management, then when you are struggling and when you are failing to progress down the algorithm, I think people won't turn and help you. So I try to make sure that I make a point of empowering my team and telling them that it's their responsibility, to nudge me down my algorithm if they see me getting stuck. I think there's some language that can help us when we're in our airway algorithm and things aren't going well. I think we have a tendency to minimize in our language. So we like to say things like, I'm having a bit of trouble visualizing the glottis, or I'm having a bit of trouble bag mask ventilating, when really what we mean is this attempt at laryngoscopy is unsuccessful. I've been unsuccessful at passing the tube, or this attempt has failed. I think when we use clearer language like unsuccessful or failed, it prompts our team to recognize that we need to move on to the next step. If we say things like, I'm having a bit of trouble visualizing the glottis, or I'm having a bit of trouble passing the tube, then people want to hand you a bougie, or they want to offer you another blade, to have another look. But I think if we use words like failed or unsuccessful, that's going to prompt us to move to our next steps. I think that when we start to get into our second and third steps, this is also our opportunity to start priming us for what's coming later. It really is like emotionally challenging to get our heads around putting a blade to the front of the neck of someone we were not anticipating doing that for. And again, recalling this situation, this gentleman was actually a semi-elective hernia repair with no predictors of difficult intubation. So we didn't go in planning to access the front of the neck. So I think the earlier on in this failed airway algorithm that we start to acknowledge that possibility, the better. So when we're at bag mask ventilation and that's unsuccessful, I think having named can't intubate, can't oxygenate as our algorithm, I think that was helpful in our situation in giving us all a bit of time to get our heads around what we needed to do. I think announcing that this is going to be our last rescue attempt, and if this fails, we're going to need to access the front of the neck, again, primes people to both physically get ready and cognitively get ready. And when that supraglottic airway failed, using words like front of the neck access or surgical airway, that's going to prompt us to move forward into our final step of the algorithm. What we really want to do is make this algorithm so easy that it's like falling down the hill. So this is kind of how I think of it in my head, as I put myself at the top of this algorithm and I basically just fall forward, and I'm committing to not stopping until I get to the end. So in summary, in an intense crisis situation, whether it be a can't intubate, can't oxygenate, or some other crisis, anticipate that your brain will shrink. This was sort of an extreme example for me, and I'd never experienced anything quite like that. but I do think that it's pretty common that we're going to have that kind of a situation. So we need to prepare for it. Ways to prepare for that are to empower our team, to use our team to the best of our abilities. And amongst the techniques to try to do that, or we need to plan, we need to communicate, and we need to execute our plans. Hopefully there's some good learning in there for you. Hopefully you'll never find yourself in a can't intubate, can't oxygenate scenario. But if you do, maybe some of these tips will prove useful for you as well. Once again, thanks for choosing to listen to my talk, and I'm probably sitting right over there waiting to answer your questions if you have any. Thanks again.